Good afternoon, ladies and gentlemen, and welcome to your Healthcare Intelligence Network conference call. All lines have been placed in listen-only mode, and the floor will be open for your questions and comments following the presentation. At this time, it is my pleasure to turn the floor over to your host, Melanie Matthews. Ma'am, the floor is yours.
Thanks, Ellen. Welcome to Medicare Chronic Care Management Billing, Leveraging Population Health Management for Successful Claims Submission, sponsored by the Healthcare Intelligence Network. My name is Melanie Matthews, and I'll be your moderator during today's session. You should have your conference materials, including the agenda, background information on our speaker, the conference materials prepared by our panelists, and our conference evaluation form. If you are having difficulty logging into the webinar portion of today's conference, please call us at 888-446-3530 for instructions. If you did not have the opportunity to download and print a copy of our conference handouts prior to today's call, you can do so now by clicking on the Handouts tab in the Conference Materials section of the webinar screen. We will be tweeting live from today's program at hashtag Chronic Care Code if you'd like to follow along on Twitter or post your own tweets. Today's conference will last approximately 45 minutes. Our speaker will present, followed by a question and answer session, during which you'll have the opportunity to ask questions of our panelists over the phone and via the chat window in your webinar screen. We're so pleased to have with us today Deborah Burberry, RN, Clinical Quality Assurance Manager with Actoris Healthcare, who will share with us today her organization's approach to billing for chronic care management. Deborah?
Thank you. Good afternoon, everyone. I would like to thank Melanie and the Healthcare Intelligence Network for this opportunity to present on this topic today. It's something that our group is very passionate about, and myself as well. I'd like to give a little bit of background on myself first. My nursing background started in a hospital setting, and after several years I moved on to the outpatient setting. I have worked in the area of home care as well. I'm currently working with a 4 primary care practice that makes up Arcturus Healthcare Group. It includes 42 primary care physicians, nurse practitioners, physician assistants, and staff. My focus the past year has been with 3 of the groups, which have 20 physicians, 3 nurse practitioners, and 1 physician assistant. This primary care group consists mainly of specialties of internal medicine, family practice, and pediatrics. So a couple years ago, this group decided to create the Clinical Quality Assurance Department, of which I'm currently managing. Our focus was on creating and implementing evidence-based care workflows and care coordination for our chronic disease patients. We have several programs in place for care management. We initially started with a lean management program that we focused on our diabetic patients. And then after that, we advanced to working with a program through our physician organization that's called MyPIC. And in Michigan, it's called the Michigan Primary Care Transformation Project. Within that project, CMS created a grant which allows us to have a registered nurse, a dietitian, a certified diabetic educator, and a social worker on site 4 days a week. And they meet with our patients one-on-one. There is no cost to the patient as it's covered through this grant. And patients really love the one-on-one experience that they get from the educational opportunities for those meetings. The next program that we just rolled out as of the end of last year is called HICM, or High Intensity Care Management. And in that program, we have a nurse practitioner and a social worker that make combined home visits to patients who have been identified as having 6 or more chronic conditions. And those patients, by working with them, they're hoping to prevent further admissions. The third program that we've put into place is our transitional care program. Our nurse practitioner receives a daily electronic report that reflects our admissions and discharges for that day from the hospital. She will then contact those patients and initiate an encounter through the phone call for that transition from the hospital to the home setting. And she then will schedule follow-up visits with our primary care physicians in our office. And now in 2015, Medicare is bringing us the CCM program, or chronic care management, which will allow us to continue to follow these patients through phone calls, monthly monitoring, and electronic portal as well. My goal today, though, is to share with you what we're doing within my group for chronic care management, and I hope that you'll be able to share with me as well what you're doing within your group. In today's agenda, I'd like to cover just a general overview of chronic care management as detailed by CMS, which can be kind of complicated. We spent a lot of time studying the regulation for this program to make sure that we would be in compliance. So there are a lot of rules to follow regarding eligible population, the service requirements. There are overlaps of do's and do-nots as defined by CMS. There is a participation agreement or patient authorization agreement that is very detailed that you need to come up with. There are care plans that have to be documented and implemented. And I want to talk about what we've done and see what else we can do here within your own groups as well. So I'm hoping I learned from you as well. CMS recognizes that care management is a critical component of our primary care setting, and it can help contribute to the better health of our patients and also reduce spending as well. Our group has looked at this as an opportunity to capture more revenue as well as improve our patients' health conditions. However, when we first started studying the regulation, we found out that it wasn't going to be quite that easy. They've put into place many requirements and guidelines that need to be followed to qualify for this service. And we think that one of the biggest messages that stood out was the fact that 75% of healthcare spending is directly related to chronic conditions. The prevalence of comorbid conditions also presents a challenge for disease management, and most of these patients fall into that category. The program was going to need a comprehensive effort to reconfigure our clinical workflows and processes to address the needs of these chronically ill patients within a primary care setting. And one of the main things we determined we really needed was physician leadership. Involvement by our physicians to support this program was going to be a major key to success. I was very fortunate to work with my physician medical director, who does provide that support for our department, and we were able to move forward. I think one of the things that you may need to look at if you're just starting with this process is you need to create within your group a physician buy-in for disease management activities in order to create that culture, or you will have a difficult time of having sustainability for chronic disease management. The cost of disease management, of course, continues to drive a lot of our decisions in encouraging our patients' self-management activities that will be complementary to the patient-physician relationship. Strategies for supporting patients and becoming informed and active participants must be extensively developed. Sorry, I think I missed a slide here. The potential revenue for this code cannot be overlooked. It's remarkably very, very high, but it will be very difficult to accomplish it. At the same time, we have some barriers that we've identified on this. On this slide, you'll see that 20% of our patient population has Medicare on the average, is what we're being told, and 68% of those patients will have 2 or more chronic diseases. So we identified that we could have potentially maybe 2,300 patients, 2,400 patients within our group that have 2 or more conditions. And each of those patients have the potential of being reimbursed approximately about $42 per month. So the potential revenue could exceed $100,000 per month or $1 million per year. However, this requires a lot of time and effort for the staff that's going to be involved with this. And later on, I'm going to discuss some other options and ways we can proceed through that. A little bit of the overview requirements. Again, it's quite a complicated program. Medicare has stated that chronic care management must include at least 20 minutes of staff time, must be directed by a qualified healthcare provider per calendar month. The patient must have 2 or more chronic conditions expected to last at least 12 months or until death of the patient. A comprehensive care plan must be created, it must be implemented, it must be revised and monitored on a regular basis. You must have certified EHR technology, and there are several categories of who qualifies under billing for chronic care management. Medicare has suggested clarifying some of those points with them if you're not sure. Here at Arcturus, we have identified under the Incident 2 rule that our registered nurse is going to be providing these services under the care of the patient's primary care doctor. I have since also learned, though, that licensure of stat varies from state to state, so you will need to check with your state regulations. And only one practitioner can be billed per month. And one of the items that came up in one of the CMS webinars was the fact that when you're billing this code, perhaps the specialist has decided also to engage the patient in this code, and it's kind of whoever gets their billing in first in that month is the one that's going to get paid. So you may have to look at when you're going to be generating your billing as well in some of those categories. Certified technology is a requirement, and you'll have to look at what you have in the way for EMRs. Here again, this slide just references some of the information that I just gave. I'm sorry, I need to go back. The eligible population was one of the first factors we needed to look at. So again, our beneficiaries must have 2 or more chronic conditions that last 12 months or until death. In Michigan, we were able to identify that beneficiaries from Medicare Advantage programs also are qualifying for this code. And pretty much what we did was we actually just started calling our payers, customer service line, and looking up individual patients with plans and asking them if that CPT code was a service that would be covered for them. And that was how we determined some of our eligibility. And we since have been paid on that as well, which I'll get into later. One of the other aspects that's really important, CMS requires prior to billing the CCM code, the patient must have been seen for either an annual wellness visit, the initial preventative physical exam, or a comprehensive E&M visit as well. So that's something else you have to work into your workflow. How is that going to happen? How are you going to identify those patients that have already had those services so that they're eligible for the CCM program? This slide, again, is a little bit of a review. The scope of the service is not really well defined in some areas by CMS. I think they continue to evolve the program as they go. However, some of the points that are very clear that you need is the patient authorization or patient agreement form. Patients must be aware of how to access their provider at all times. There must be the comprehensive assessment done at the time as well as the care plan created. And once the patient agrees to be part of the program, they have a signed authorization that they must sign, that you must keep. We're scanning it basically into our medical record. They must know that they have the right to cancel that agreement at any time. And there are very strict documentation guidelines that fall into this process as well. Communication and coordination with care obviously must be provided as well. There also are some factors that are involved with the overlapping of the CMS initiatives. So if transitional care management is being provided during the same time period, that would take precedent over you billing the chronic care management code. So in my office, when I identify a patient that's coming from the hospital and we're going to see them and we're going to bill the transitional care management, I would not provide CCM services for them during that time period. The CCM services would follow in the next 30 days or the next month. sorry, I'm clicking the slides a little too quickly. The participation agreement is very detailed, and on the next slide I've provided a copy of one that we actually created. The assessment of the patient's medical, functional, and psychosocial needs are included in the documentation of the chronic care plan. There is a system-based approach of the timely receipt of preventative care. Medication reconciliation must be adhered to and documented and reviewed. Patient-centered medical approach is used through all of these services. The care plan itself requires a great deal of documentation as well. We participate with Allscripts, so in our EHR Pro, we have the ability to have some templates that are currently already built into the program. So it makes it a little bit easier for us to follow a protocol on what we're documenting for the patient when we're seeing them for CCM. First thing that we document is the actual participation agreement, that it was obtained by the patient and that the patient has accepted or declined that service, with a copy, as I stated, being scanned into the medical record. The comprehensive care plan must be created and documented following the complete assessment of the patient's needs. So must include referrals as well as supportive measures that are being offered to the patient and who is responsible for those interventions. It must include preventive services, social family history, immunizations, diagnostic. This is a care plan and goal that we have available within our Allscripts EMR. So we are able to actually set up a goal for the patient. It has to be associated with a diagnosis. The patient's status is then identified and their engagement level is identified. And then the plan is created. So under goal, I can establish items like decrease emergency room visits, or manage their diabetes, or manage their hypertension, or quit smoking, weight loss. And then you establish a patient engagement level of, are they avoiding the change? Are they considering or preparing or making the change? Are they maintaining the change? And then in the status field, we can put, have they started, suspended, abandoned, or met that? And then we identify barriers within the plan itself that they will help us identify. So the first goal that we add into our care plan is the understanding of the chronic care management agreement. Then we move on into our medical management. One of the examples that I just had with one of our patients is she wanted to manage her hypertension, and she was a patient who was a diabetic as well as a bariatric surgery patient. So her goal was to exercise daily, walk 5 steps each day, walk up and down her driveway, and do some light arm exercises. So we managed to work with her, and on a weekly basis, she is now walking 20 to 30 minutes, 3 to 4 times a week. She does pre-medicate herself because she has some knee pain still, but she's still losing weight, and she's been highly successful from the initial goal. And this particular patient, actually, we have billed 2 months in a row already, and have worked with her, and we're really, really happy for her, the successes that she's having. And, of course, with these patients, it's all about baby steps. You have to make the goals that are attainable. So we work with the patients to make sure that they're realistic goals. One of the things that we did a while back was the patient had to establish the goal, but in this particular play of when we're working with the patients, the doctor works with them a little bit more in establishing that goal. So we still want it to be attainable as well, though. So we really have a head start on documentation, I feel, because of the components that we have available through our EMR. One of the apps that I have been researching, and I'm not here to promote this particular program, but one of the problems that we have with the program is the documentation of the time requirement. It certainly is a barrier. So we currently are just documenting the time spent on the phone within the care plan. And that's working for right now, but my concern is for the future when I'm going to be having a larger volume of patients involved with this program. I don't know how I'm going to be able to do that. So some of the suggestions were, of course, log sheets and Excel spreadsheets, which we're currently doing right now because of the small volume of patients that we have. However, this particular program called Discharge IQ, it was created for a care manager from a hospital perspective. However, we really liked the possibilities with this program. So they developed a phone app that the patient logs into each day. And the phone app has guidelines set up based on whatever parameters you determine for your chronic condition that you're monitoring. So if a patient has congestive heart failure, let's say, and you want the patient to perhaps enter what their blood pressure is and what their weight is that morning. Once the patient goes and logs into the app and enters that data, it will show up on a dashboard that I will look at on my end, and it will do some risk stratification based on the guidelines and the parameters that you have set to determine whether or not that patient needs to be called back immediately or if it can wait. So you can't, it's difficult to see the screen, I realize, but in the middle you'll see some little red circles. Those patients were the patients that were identified as a higher risk for that day. So what I liked about the program is that if you have 200 patients that you're calling during the course of 5 days, it could risk stratify those particular patients, as well as every time you logged into that patient on the program, it tracks your time to the second. So you didn't have to worry about audit purposes later on as to what how much time and minutes you've spent engaging those patients. So I just want to throw this out here because there's some options in how you're going to be able to track time, and you have to figure out what works for you and based on your volume as well. There is another group that our EMR is using in Allscripts. They have a relationship with Allscripts in Florida, and what they're doing is we would do the initial assessment of the patient and the engagement and get the signed authorization, and then they would do, and we'd set the care plan up. Then they would do all the follow-up phone calls. So our involvement would be engaging the patient, but yet they would do all the tracking for us. Now, obviously, there's a fee involved with that, and they take a considerable amount of your $42. But if you're looking at a large volume, for us to be engaged in that program, it wasn't going to cost us anything up front. So we weren't going to be losing anything, and it would allow us to involve more patients. My only concern about that is that right now, the relationships that we're establishing with patients are really important to us. So, but it's another program, is something else to look at for a future as this program evolves. Provider and staff involvement is really important. That you really need to identify who your champion physician is that's going to support this, who your key staff players are, what staff will be providing the service, what teams of staff will assist you in coordination of this, and how are you going to sustain these processes. I think your leadership must create momentum with staff and patients for sustainability of the program. So that's what we kind of did. We started with our key players. We identified our champion physician. We identified that our registered nurse would be the staff member that would be involved with these patients. We went into our EMR, and we were able to create some reports that would identify our eligible populations. So I'm looking for patients that have Medicare, that I'd identified 2 chronic diseases, diabetes and hypertension. And then I needed to identify patients that were coming in within the next 30 to 60 days. So those parameters were put into our report. The report was created, and then physicians were identified whose patients belong to who. The physicians were then asked to review these lists and identify our potential patients that they felt would be good candidates for this program. Who would you be able to engage to make sustainable changes to help produce these positive outcomes for these patients, or who perhaps would not? So the physicians were involved right from the bat. They identify these patients. They review these lists on a weekly basis, actually, and it only takes a couple minutes because my concern was, you're asking the doc to stop seeing patients and look at lists again, but it really hasn't taken them that long, and they're happy to do it. They know these patients really well, so they know right off the bat, nope, that patient, I've been working with them for a long time. I know they won't do this or whatever it is that they know about the patient. Then these patients' visits were identified in the schedule. So when they come in to see their doctor for that well visit, physician would preface the program at the end of their visit. So our nurse then comes in and introduces herself to the patient. So now the patient has seen her face. They know who they're going to be speaking to on the phone every week. And the nurse also has an idea of the patient as well. So that works, as a twofold for both ways. It allows the nurse to sense more about the patient and seeing the visual as well. The nurse explains the program again to the patient and reviews the patient authorization form. They obtain the signature at that time. The patient's provided a copy of that authorization form. It's scanned into the record, and then documentation occurs into the care plan. And at that conversation, a time is established by the nurse and the patient as to when is a good time to contact them in the next few days, so they can talk about what goals the patient would like to address. And then prior to that, the nurse has also been reviewing with the physician what goals does the physician have for that patient. What priorities could be established that we need to work on with the patient? And so then the nurse can review those goals with the patient when she calls the patient back and tells the patient, I've talked with your doctor. This is what your doctor feels that we should be working on. How do you feel about that? And so they establish their goals and the plan, and then the discussion is then centered around whatever the patient agrees to in that plan. Now, when the nurse first contacts this patient, this phone call takes a long time. She has to do a complete assessment over the phone of what we spoke about earlier, and depending on how many chronic conditions that patient has, it can take at least an hour. So, and remember, most of these patients are very complex. We're identifying 2 chronic conditions that we want to work on with the patients that we're setting up goals for, but the majority of those patients have more chronic conditions than just 2. And again, those goals need to be set up so that they're attainable for the patient. We don't want to set the patient up for failure for that. Time frames are established as to the frequency of the calls at that time with the patient, and precedents set up as to when's a good time for us to call you back so that you would be available. So the subsequent phone calls only don't take that long at all. And what we're currently doing is making calls like on a weekly basis. So by the time you document 4 to 5 weeks during the course of the month, you've easily met the 20-minute minimum, especially following the initial assessment. Documentation of the first contact takes quite a while as well, so whoever your staff is, they need to allow time for this. Then the patient has to receive a copy of that care plan that's created either electronically through our portal. We can send it if they have a web portal, or we mail them, and then each time the care plan is updated and changed, which usually is on a monthly basis. If you're seeing successful outcomes, then that has to be recopied and forwarded to the patient as well. To date, I'm probably proud to say that we have been paid by Medicare, $41.32 on these patients. A couple of our patients had Blue Cross as secondaries, and their copay was $8.68. The Blue Cross PPOs paid the copay, so the patient had no out-of-pocket costs. Our Medicare Advantage patient was allowed $40. They paid $30, and the patient did have a $10 copay with no secondary, unfortunately. But again, some of the barriers that we've identified with this program are the time that's going to take for you to document and track, and identifying our patients, as well as the cost. We really thought the out-of-pocket cost to patients would be a deterrent for the program. And we have had some patients who have refused and said, no, I don't want to do it. So you're not going to get everyone to sign up, but we're hoping to make some effective changes with the patients that we have had sign up. I've included some resources within the program. One of the best resources is this Medicare Learning Network. They have had some webinars that have been really, really good with question and answer period as well that answers quite a few questions regarding the program. And then my last slide that I've provided is something that I can't do. I don't know how many of you can do this, but I would certainly like to do this when I'm her age, at least. So, and again, our goal is for prevention and the health care of our patients. So I think our care managed programs are working in that direction. I'd like to thank you so much for your time and attention today. I hope I've brought some new ideas that are working for us that you may be able to use in your programs. We are very excited about this program and the opportunities that it brings to us as well as our patients. And we have seen over the last year what we've been doing, this one-on-one engagement with our patients. There's so much value to this. Our patients just love it. Some of the examples that I can provide for that would be we've had just simple little things that we've done. A congratulation card that we sent to the patient after she lost this weight that she was working on. And she came in for her visit and she said, I have that card on the front of my refrigerator. And I ate something yesterday I shouldn't have eaten. My husband threatened to take that card off the refrigerator. And she said, I told him he couldn't. We have to leave it right up there. So that's kind of my motivation and how proud she was of her accomplishment. And it was just a simple little thing that we decided to start doing to recognize the patient's accomplishments. And one of our doctors, one of their patients had come up to him and said, Marianne is one of my staff members, had been calling him, who's a diabetic patient, and he said, make sure you tell Marianne that I did this. And he said he was so excited about letting Marianne know that he didn't even recognize that the physician involvement with that. I think our physician was a little put out by that, but we were still excited for Marianne that he said she doesn't have to call me every week now. So, but patients really like the one-on-one, and that relationship I really feel passionate about. That's the only problem that I see with some of the programs, like the discharge IQ and that. If someone else follows our patients, we are going to lose a little bit of that relationship, and I think that is very conducive to being successful to our patients. One of the other things that we found with our patients is that they really need more education on their chronic conditions. So education has been a large component of our care management program. As well as for our staff, we have established some relationships with our pharmaceutical companies who are now bringing in programs for our staff and patients without branding information. And so they have been very, very helpful. And we are also considering investing in some healthcare coach training for our staff as well. So we're very excited about moving forward in the direction of care management. Thank you very much.
Thanks, Deborah, for that practical, informative presentation. We are going to open our phone lines now for our question and answer session. To join the question and answer queue, please press *1 on your telephone keypad. Please remember to take your phone off mute when you are selected to ask your question. To ask a question via the web presentation, at the bottom left-hand side of your screen, type your message into the box, select the Q&A session in the To field, and click on the blue Send Message. Deborah, how many patients have you enrolled in the program?
Well, this is new. We're only in our second month, so we have about 6 right now, and I've been paid on 4 of them. So, but we continue to enroll more each on a weekly basis. Okay,
great. You mentioned that the RN is responsible for managing those patients. How many patients do you think the RN can manage under the chronic care management requirements?
Well, the initial assessment is about an hour. So until some of these patients are enrolled, that you're only going to figure an hour per patient per day. So you're going to be limited until the patients are actually in the program. At that point, it's only a few minutes, and the key to that is establishing a time that you can reach the patient, so you're not playing phone tag with the patient. If you can establish a certain date and time that you call them back, they're expecting your call and you get right through, and then she's only on the phone for a few minutes with them. So we're anticipating at that point, if you had multiple patients enrolled, we could manage a couple hundred patients a week, but I don't know, that remains to be seen since this is all so new. And the other thing is, I don't think all of the patients will be in the program. There'll be continual rollover. So the patient that meets their goal at a few months may drop out of the program, and you'll enroll new patients as well.
Thank you. How are your practices working with specialists on chronic care management?
Well, we have the ability through our EMR to send information back and forth through the specialist, and that's one of the components of meaningful use as well that we're involved with, so we can have direct contact with them.
Thank you. You mentioned that the timing of when you generate the billing can be critical in terms of the patient attribution to your practice. Can you provide any advice on this?
Well, what we're trying to do is by the last week of the month get all of our billing in. So, but that doesn't mean, I think in referencing that with the CMS webinar, you could potentially bill on the 28th of the month, and someone else could bill on the 2nd of the month. And that may overlap, if there's a specialist that's involved with CCM. We haven't had this come up, but I would hope that if we were aware that a specialist was also engaging the patient, perhaps we could coordinate that together somehow. I don't know that I think is going to happen. I don't know what's going to happen at the point. We'll have to work with our specialists on that. And we do have preferred specialists that we work with, so I'm hoping that we can have a relationship in that area.
Thank you. How are you making sure that you're not billing for TCM and CCM in the same month?
Well, our nurse practitioner and my CCM nurse, they coordinate that together.
Thank you.
And so our TCM nurse practitioner is also trying to identify CCM potential patients for the future. So I don't think we're going to have an overlap with that. They're pretty good about communicating with each other who's in which program.
Thank you. With regard to the applications that you're using for the patients, do Medicare patients use the apps with ease, and how are you educating patients on the use of that app?
Well, we're not using that. That's something that we're potentially looking at. So I can't really answer that. The statistics show that Medicare patients are involved with technology, so we haven't got to that point yet. So, but I know our EMR has a lot of technology involved in some of their programs. They have a program called Achieve where the patient very well could take their blood sugars at home, and it could automatically load into our patient portal and it would go directly to the physician. But we have not engaged patient in any of that yet, but we are looking at it for the future.
Thank you. What resources did your practice have in place that were critical to your ability to bill for these codes?
Well, I've done a lot of research for a long time. We've just poured over the Medicare regulation to make sure that we were meeting all the requirements, and then attending the Medicare Learning Network webinars, and just keep comparing notes to make sure that we're doing it correctly.
Thank you. What are the top chronic conditions you're seeing in your practice?
Diabetes and hypertension, obesity, congestive heart failure, and kidney disease. COPD and asthma. Those are the main ones that we identify and work with within our chronic disease management program.
Thank you. Were there any initial hurdles when you first billed Medicare? And then how about the Blue Cross plan?
No, the only hurdle was my impatience of waiting the 2 weeks to hear whether or not they were going to pay it. No, we just billed it, and it wasn't rejected or anything. It just came through as a payment. The secondary went to Blue Cross, and we were surprised when Blue Cross paid it. So, no, I can't say there were. It was your typical billing of Medicare.
Good. That's great to hear. For the patients who have copays, has there been any negative feedback?
Not yet, because I've only had one patient who has a copay. So,
okay.
And that just came through this week, so I'm not sure the patient's aware of that. But we talk about that. That's part of the patient authorization agreement. The patient has to know up front that they may have an out-of-pocket cost involved with this. So they're prepared for that. They know that. That is part of the program requirements.
Thank you. You alluded to the ability of the RN manager to build a relationship with the patient. And one of the challenges that we're starting to see is the ability to coordinate the care coordination. So, you mentioned about if a patient is hospitalized, then they're touched upon by the transitional care nurse. And if they're part of the chronic care management, then they're being managed also by the RN care manager. Can you just talk about that challenge?
Well, I think our biggest problem with that is that we don't want to overlap anything, but I don't think they will, because they're essentially doing different things. The nurse practitioner, when she's contacting the patient from the hospital, she's making sure that they have their prescriptions filled, and what other kind of resources do they have away, travel to get to the hospital, to the office? Do they have any family support? Do they need someone to come to the home? She's identifying different things than chronic care management is identifying, for me at least. That's how I feel. The chronic care manager is going to look at long-term problems that need to be addressed on a daily basis. And the transitional care program is working on the transition from the hospital to the home setting needs. So I think it's just a great team effort on both their parts that everything is getting covered with the patient. There may be some overlap with medication reconciliation and that, but I think they're really branching off in different directions in the needs meeting the needs for that patient.
Thank you. How will this impact non-Medicare patients in your practice?
Well, our non-Medicare patients are able to receive care through our other programs. So I don't want to say we're treating them differently, because we're not. They might be an advocate for, if they're a diabetic, they might be an advocate for my diabetic program. And so within my diabetic program, my staff is calling patients that have elevated A1Cs that we're working with to lower on a weekly basis. And they're talking with them about their insulin doses and their blood sugar diaries, and they're capturing all that information through a phone call, just like the CCM is. The difference is that you're not getting directly paid for that care, but you still have to provide those services for those patients. We're not going to isolate patients and say, you have this insurance, so I can't call you, even though your diabetes is not where it needs to be. It's not managed well, but this patient I can, because I'm going to get paid. We don't do that. So all of our patients are being addressed in the same manner. We're looking at evidence-based care. We're trying to create workflow and process that manages the diabetic or the hypertensive patient or the obesity patient all in the same manner. It doesn't matter what their insurance is. It's just that if they happen to have Medicare, then this program can be extended out even further and can generate revenue with it.
Thank you. We have just about a minute left. Can you just quickly talk about the features of the other care management programs that you mentioned? You talked about the HICM and the MyPIC.
Yes. Well, the MyPIC program we've been doing for about 3 years now, and Medicare just extended it. It's been a terrific resource for us to have these members in our office. When I have a newly diagnosed diabetic, I need to get them to a certified diabetic educator as soon as possible. And we are able to do that with her. Maybe she won't be in the office that day, but I can call her and she'll come in and meet with that patient the following day, so we can get that patient started right away to help get their blood sugars down and control that diabetic. And then they can follow up with her as well. And those are one-on-one visits. They're usually about an hour long per visit. So the patient has a lot of time that they get to spend with that person, and they can bring family in with them as well. So they get their questions answered, and the patients just absolutely love that service. So we're able to identify, our nurse works with the hypertensive patients. The social worker might work with our patients with behavioral health or depression or whatever is going on socially at home. I mean, just having all of those members be able to be part of our team, and we don't have to pay their salaries because we wouldn't be able to afford to have those types of services within our office setting. So that's what's great about the program.
Thanks, Deborah. We are out of time today. I want to thank you all for participating in today's conference. I especially want to thank Deborah Burberry for her hard work and time in preparation for today's program and for the insight she has shared with us today. We welcome your thoughts and comments on this conference. Please email us with any questions you may have. We urge you to take a few minutes now to complete our conference evaluation form. A few minutes of your time today will help us shape future programs. If any of your colleagues were not aware of today's conference, or if you feel this program would be a valuable discussion tool for planning sessions, an on-demand version of today's proceedings will be available tomorrow, May 22nd, and a CD-ROM or DVD version will be available on June 11th. Call our customer service department today at 888-446-3530 to reserve your copy. This concludes our conference for today. I'm Melanie Matthews, and once again, thank you for joining us. You may disconnect your lines at this time, and have a great afternoon.